Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today we're doing a podcast on the article titled Circulating Tumor DNA in Endometrial Cancer, Clinical Significance and Implications. We have three of the authors of that study, Ilaria Capasso, Camilla Nero, and Evelyn Reynolds. I would like to thank you for accepting the invitation to the podcast and welcome.
Thank you. Happy to be here.
Thank you so much.
It's a
Excellent.
great pleasure.
Thank you so much. And once again, of course, obviously, thank you for submitting the article to our journal. So lots of topics to be discussed. And we wanted to start by asking question regarding insights regarding the timing between ctDNA positivity and radiologic appearance of disease, particularly in the context of recurrence. For instance, how much earlier can ctDNA detect disease compared to routine imaging?
Thank you so much for your question. Well, although data answering this issue are few with respect to gynecologic malignancies, previous studies on breast cancer reported that ctDNA detection had a median 8 months lead time over clinical and radiological relapse. Also, a similar predictive lead time of 7 months was identified by Pereira and colleagues in gynecologic malignancies, and a lead time of 2.5 months preceding clinical and radiological relapse was identified by Moss and colleagues in the specific setting of endometrial cancer.
Great. And again, I mean, I think certainly circulating tumor DNA is a very hot topic in gynecologic oncology. Particularly on how we use circulating tumor DNA. So I'm going to turn over to Camilla now and ask, are there currently any malignancies in which surgeries are planned according to ctDNA detection preoperatively?
So it's a very interesting question, and to the best of my knowledge, no, but the correct answer would be not yet, because ctDNA is increasingly being investigated in the preoperative planning of cancer surgeries. The reason why it's routine clinical use is not yet actual in clinical practice is because there are several limitations regarding the sensitivity in early stage tumors, which are the ones that go to surgery, because the level of ctDNA can become very, very low, and therefore it's challenging for the current methods to detect it. There is a lack of standardized thresholds or interpretation frameworks. And finally, there are no prospective trials that validated this approach. So ongoing trials are now validating and actually evaluating the if ctDNA positivity preoperatively can actually alter the extent of resection or inform for neoadjuvant treatment, at least in colon cancer, non-small cell lung cancer, breast and pancreatic cancer. But I guess in the future, we're going to see much more broader indications for this kind of trials.
Excellent. Thank you, Camilla. Now we'll turn back to Ilaria for this next question. And, as Camilla mentioned, of course, obviously it's being used in a number of other cancers in gynecologic oncology. Lots of it is in the setting of ovarian cancer. Now, this next question is, why do you think the rates of ctDNA detection for endometrial cancer are so low? It seems that it's about 15 to 30% of patients.
Well, ctDNA shedding and detection depends on several factors. So notably, not only the percentage of detection is reported as low, but it also is very heterogeneous depending on the assays used for detection that are mostly based on PCR or NGS. The first factor to consider is surely tumor biology and spreading capacity of the tumor. And indeed, endometrial cancer presents in approximately 80% of cases as a low risk and uterine confined disease, as we all know. And it has been shown that tumor presented with advanced metastatic disease release more ctDNA in the bloodstream. But beside primary tumor characteristics that also include site of metastasis and tumor necrotic index, There are pre-analytic factors that need to be taken into account, such as blood drawing, blood collection tubes, the effect of processing samples and centrifugation, and also the methods of extraction. Therefore, it is likely that these low ctDNA detection rates reported in the literature might be depending mostly on the overall indolent and low-risk presentation of endometrial cancer.
So, Ilaria, along those same lines, then, one of the questions that we were discussing when looking at this article was the detection of tumor-derived DNA in tissue, such as cervical or an endometrial sample, compared to plasma ctDNA in terms of sensitivity or specificity for early endometrial cancer diagnosis.
Thank you for this follow-up question. Very few studies, such as the one from Jiang and colleagues, were able to detect tumor-derived DNA in the endometrial cancer and atypical hyperplasia diagnostic setting, with a concordance of approximately 40% between solid tissue sampling and serum ctDNA. However, the same authors reported a higher diagnostic concordance in detecting tumor-derived DNA using Papa-Nicolau cervical smears, approximately 82%. Similarly, another study from Kim and colleagues observed a sensitivity of 67% and a specificity of 100% in the detection of tumor-derived DNA in the cervical smear of patients with endometrial cancer, in addition to reporting high performance of this technique in identifying tumor mutational signatures. Therefore, from these few data present in the literature, it looks like sensitivity of non-blood fluids, such as cervical and intrauterine fluids, is higher in detection early stage endometrial cancer compared to detection in blood.
So now I'm going to turn to Evelyn for this next question that we were discussing as well. The question is, if identifying molecular subtypes using ctDNA, p53 mutations would naturally be of particular interest. So is there data on the potential interference from age-related somatic mutations due to clonal hematopoiesis?
Yes, thank you for the question. So clonal hematopoiesis is certainly a barrier in the accurate detection of ctDNA for clinical use, as it contributes to the false positive rate. Excuse me. The definition of clonal hematopoiesis of indeterminate potential, or CHIP, is a process that results in accumulation of somatic mutations in hematopoietic stem cells, leading to the clonal expansion of specific mutation in blood cells that could lead to the development of a hematologic malignancy, such as MDS or leukemia. This is an age-related process occurring in about 50 to 60% of patients over the age of 80. But it's also increased with chemotherapy, particularly in platinum-based treatments or PARP inhibitor therapy, which are common in GYN cancer treatment. So clonal hematopoiesis can result in false positive ctDNA detection, particularly for mutation-based assays. There have been several studies evaluating the rates of clonal hematopoiesis in ctDNA, with one study of preoperative ctDNA in colorectal cancer having 17% of detected mutations being from clonal hematopoiesis, and another study identifying 15% TP53 mutations being related to clonal hematopoiesis in non-small cell lung cancer. However, in patients with metastatic or recurrent cancer, this rate can increase up to 50% in various cancers. But none of this has been studied in endometrial cancer to date, given that patients with metastatic or recurrent endometrial cancers usually receive platinum-based therapy, and with the DUO-E clinical trial resulting in the approval of olaparib in proficient MMR patients for advanced stage endometrial cancer, these rates are likely to be higher. Ultimately, additional studies are needed to differentiate clonal hematopoiesis from somatic mutations in endometrial cancer.
All right, excellent. Thank you, Evelyn. And I'll turn to Camilla for this next question, because often obviously frequently now we're discussing what do we do with these results. So this next question really targets how should we currently manage a ctDNA positive result with a negative radiological assessment during routine surveillance, considering the specificity of ctDNA at 85% as presented in this review. Should this prompt an intensified follow-up strategy or the initiation of systemic therapy?
Thank you very much for this question. It's absolutely a hot topic today in the current management of oncological patients. So at this stage, I have to admit that evidence is still not sufficiently solid in number and quality to provide base for escalation of treatment based on the detection of ctDNA. However, in those cases with detection of ctDNA during follow-up, especially those who did not have previously detected ctDNA, I would probably suggest to intensify follow-ups and probably integrate with a second-level imaging. However, after the finalization of the high quality and prospective data, I personally strongly believe that ctDNA detection will guide not only escalation, but also de-escalation of treatment in the next years.
Great. And along those same lines, then I'll turn to Evelyn to ask with regards to how do we deal with the results of these tests. A potential intraoperative tailoring of primary staging through preoperative ctDNA detection is a potential possibility. So in an ideal world, how or what would this look like particularly?
Yeah, so studies have shown that preoperative plasma detection of ctDNA correlates with aggressive clinical pathologic features, non-endometrioid histology, grade 3 tumors, TP53 mutated, et cetera. And that is associated with deep myometrial invasion, advanced disease, lymph node metastasis, lymphovascular space invasion. So the evidence is conflicting in some aspects, but there is correlation between the presence of preoperative ctDNA, high-risk features, and eventual recurrence risk. How this may look in an ideal world: you get a positive ctDNA, you obtain preoperative imaging to evaluate for advanced disease. If present, then you address those areas intraoperatively. If imaging is negative at the time of surgery, your suspicion is still raised, so you may look for those high-risk features and may lead to a potential escalation of staging to add peritoneal and omental biopsies, escalating the evaluation of lymph nodes beyond the sentinel lymph nodes. Those are just some examples.
Yeah, really interesting concept and how that would play into that intraoperative algorithm. I'm going to turn to Ilaria now with regards to timing. What is the optimal time frame after surgery to assess ctDNA levels for the most accurate prediction of minimal residual disease in endometrial cancer patients?
Thank you so much for this question. Some authors observe a total clearance of ctDNA within a week from surgery, in most of the cases with preoperative detection. So this suggests that the half-life of ctDNA is short and responds quickly to the change of tumor load after surgery. Well, in comparison, CA under 25 half-life time ranges from 9 to 44 days. Therefore, CA under 25 is less likely to offer a dynamic response to tumor burden changes compared to ctDNA. And notably, inconsistencies in literature are present with respect to the proper timing for blood collection in the first postoperative period to detect the presence of ctDNA, with few studies reporting a time range spanning from 4 to 8 weeks after surgery. However, evidence on colorectal cancer reported that a decrease in ctDNA levels should already be evident 24 hours after a complete eradicative surgery, suggesting that a few days after surgery may be sufficient to accurately assess microscopic occult residual disease by ctDNA detection.
Yeah, amazing. Within 24 hours. Now I'll turn to back to Evelyn. This is sort of a hypothesis in the future type of question from one of our fellows. Given what you know about the current literature and the upcoming clinical trials, do you see a future where ctDNA could replace tissue biopsy for diagnosis of endometrial cancer?
So tissue biopsy can be an invasive and painful procedure. There could be a potential role for high-risk patients, those with Lynch syndrome, for instance, who are undergoing surveillance. In the setting of recurrence, there is also a potential role to use ctDNA evaluation if the tumor is located in a risky anatomic area. For primary diagnosis, there's a lot of information that we gather from the tissue biopsy. So with the current ctDNA assays, there is no way to replace the tissue biopsy, but we will see what the future holds.
Excellent. Now, Camilla, I wanted to ask you that, certainly it appears that most of the research is focusing on tumor-naive ctDNA assays. However, in ovarian cancer, tumor-informed approaches have shown significantly higher diagnostic accuracy. Since endometrial cancers are routinely subjected to molecular substaging, often complemented by NGS in many centers, wouldn't it be more effective to leverage this information for tumor-informed approaches, particularly for ctDNA-based therapy response assessment and surveillance?
Very interesting topic. And well, since mutation-based assays have been presented for research or clinical use for longer than tumor-informed assay, this has resulted into the majority of endometrial cancer studies using the mutation-based or tumor-naive assay. We overall agree that tumor-informed ctDNA assays have higher specificity and detection rates, as demonstrated in various ovarian cancer studies using this approach, and would be a better assay to use in endometrial cancer. But to determine if this is also the case in endometrial cancer, once for all, more studies assessing endometrial cancer with tumor-informed assays need to be done before we can draw final conclusions. Also assessing whether the clinical response for cancer surveillance can be better managed.
Great. Now, Evelyn, how should clinicians interpret and manage a mismatch between ctDNA serum findings and molecular classifications from tumor biopsy in the context of the primary diagnosis of endometrial cancer? Should this be viewed as a double classifier or rather as an indication of metastatic disease with subclonal evolution?
Yeah, good question. And it is certainly challenging to interpret the results of discordant findings between somatic mutations found in tumor and ctDNA. This could result from tumor heterogeneity. As noted in a previous question and answer, clonal hematopoiesis could result in false positive rates and identification of mutations that are not representative of the tumor itself, which may also result in discordant findings. We would recommend interpreting discordance with caution, as this more likely represents clonal hematopoiesis in the ctDNA sample rather than the subclonal evolution of metastatic disease. Ideally, the ctDNA would have performed paired ctDNA and white blood cell analyses to determine if a mutation is part of clonal hematopoiesis. Given the limitations, at this time, NGS on tumor specimens will likely yield more accurate representation, and we would not recommend altering treatment recommendations based on results purely obtained from ctDNA results.
So now, Camilla, I wanted to ask you, of course, obviously a lot of interesting data, exciting data on ctDNA. One of the most promising applications of ctDNA in endometrial cancer is its ability to detect recurrence earlier than the traditional follow-up methods like imaging and tumor markers. So based on the current state of technology and the research that you see ongoing, how far do you think we are from the actual implementation into everyday clinical practice?
Well, I believe that we can say that it's realistic to expect that within the next 5 years, ctDNA could be integrated into clinical practice for endometrial cancer surveillance, at least in high volume oncological centers. To me, this timeline depends on three key factors. The first one, demonstrating clinical utility. Can we actually leverage this information? What to do for ctDNA positive patients? The second factor is providing economic sustainability. Can we actually spare resources? Can we increase quality of life? And the third element is the technology transfer process for complex bioinformatics analysis. For instance, for minimal residual disease, only genomics could be not enough as a layer. We need to include epigenomics, which is much more complicated to be analyzed.
So then now, turning over to Evelyn, with regards to where do we see the most use? For what phase of endometrial cancer care do you think the current ctDNA data is most compelling and most likely to be implemented ultimately into clinical practice?
Yes. So with limited resources, if we had to pick just one time point where ctDNA had the greatest impact, it would probably be in the time point 4 to 8 weeks after surgery. Even if you don't have a baseline and that time point is positive, by this time point, you have the final pathology diagnosis. A positive level will let you know that this is a high-risk patient, even if the clinical pathologic features didn't necessarily suggest that. And at this time point, there is still potential for intervention. You can escalate surveillance or escalate treatment as indicated.
So with that, I'll ask the last question to Ilaria Capasso. It's a follow-up to that statement. Given that there's currently no consensus on ctDNA level cutoffs for clinical relevance in pre- and post-operative settings, and that multiple factors may influence ctDNA plasma level, how do you think the detection of a positive ctDNA level 4 weeks after surgery, as Evelyn mentioned, in the absence of radiologic evidence of disease, could impact patient follow-up strategies? Do you believe that this could lead to more frequent surveillance? Conversely, could it potentially increase patient anxiety, knowing that the biomarker is positive despite the lack of any radiologic finding?
Thank you so much. This is a very important issue, a very important topic. As also stated previously, at this stage of knowledge regarding ctDNA in endometrial cancer, we must be extremely cautious while moving in this underexplored field and avoiding drawing drastic conclusions on adjuvant management. However, presence of any level of ctDNA during follow-up, especially in patients that were ctDNA negative in the immediate postoperative setting, should somehow represent a red flag. Indeed, it is the indicator that some component of the tumor are still present and circulating systemically. For sure, it is too soon to drive escalation or de-escalation of treatment, but on the basis of what it is known now, an escalation of follow-up by intensification of surveillance might be reasonable, particularly if we keep in mind that imaging has the intrinsic limitation of lesions dimension and macroscopic recurrence might go undetected. Patient anxiety is something important and needs to be considered as a potential negative consequence of ctDNA future implementation.
Well, I want to thank all of you, Evelyn Reynolds, Camilla Nero, Ilaria Capasso, for your time for this discussion. Always really learned so much. Very exciting topic, actually, and one that we're really looking forward to additional data. And really glad that you provided this review for all of us. So I certainly encourage our listeners, if you haven't read the article, to absolutely pick it up and read it. And I want to thank all of you, and in fact, actually also all of your co-authors as well in this project. And once again, thank you for accepting our invitation to speak to us about it.
Thank
Thank
you
you for the opportunity.
Thank you very much. It was a pleasure.